Welcome to the How They Did It podcast, and I am here with Josh, my man. He's a physical therapist, really good friend of mine, and he's the one that got me through my last torn meniscus. As a lot of you guys seen, if you do follow me on Instagram, if you don't, you should. But if you don't, you would see I was injured. My knee, I couldn't bend down. I didn't think I was going to squat. I'm only 3-4 months afterwards. I'm already doing full squats. I'm back to the weights I was before. Josh really changed my mind and my entire perspective on how to deal with injuries. And we're super, super excited to have him with Lifetime Transformations, helping us with our clients. And I'm going to have him on the podcast. Hopefully he can give you some of the knowledge that he gives me. But before I try to introduce Josh and give you some of his background, I'm going to mess it up. So I'm going to let him give it to you.
Thanks, mate. Thanks for having me on. My name's Josh. I've been a physio for around 12 years now. So did all my university training in Australia. So you might need some subtitles for this podcast for your non-Australian viewers over there. Started off with a Bachelor of Biomedical Science, went into a graduate entry, Masters of Physio, been working in private practice kind of since. Worked in there for 5 years and was seeing some patients get better pretty easily, some patients not improving so much, which made me kind of do further study into a sports masters, which I completed in 2017, I think it was. So that really kind of piqued my interest around pain and why some people get better with really basic, simple things and why some people don't.
Well, that's super interesting. By the way, also you've been not only working because you're from Australia, but you've been actually working in London because that's where I met you for the past 5 years. Am I right around that?
Yeah, that's right. So I was at Pure Sports Medicine at London, so a sports and exercise medicine clinic there. Really big multidisciplinary team where we've got sports doctors, strength and conditioning coaches, massage therapists, podiatrists. So you get that real team approach where you get to learn from other disciplines as well. So really, really good experience. So finished up there. A few months ago, I was also the spinal lead area of interest there for around a year as well. So yeah, great experience. Now I'm kind of traveling and on the road here, just trying to avoid a UK winter really.
Yeah, it's a super smart move, even though you look like you belong in the winter with a helmet and axe raiding some villages. But
I like the sun. It just doesn't like me, you know.
All right, Josh. So look, I want to walk through something with you. A lot of times I get, as we know, Lifetime Transformations, we have clients that are training. A lot of the clients that come to us, they'll have some nagging injuries, maybe stuff like tendon injuries. Normally, there's obviously the big ones. There's the tears, there's the Achilles tears, there's the ACL tears, there's the joint pains. But for the most part, the most problems that we have come from the everyday little nagging, like the tennis elbows, that weird pain in your knee after you've done a couple squats, or it just kind of feels like it's a bit cranky, stiffness in your shoulders. How would you give, if you're talking general advice to these people that are starting to work out? One, how do they deal with that? Because how a lot of people deal with that is they just stop exercising completely. Are they super worried? They feel the pain. They drop everything because they don't want to get injured. Under your opinion, how do you deal with that? Obviously, on a case-to-case basis.
Yeah, so I think there's a lot of different kind of variables to kind of consider when someone's presenting with either pain or a sensation. So I think of pain on a bit of a spectrum of, you got your classic like 1 to 10 severity, and then you've got like a sensation of it not being quite right, or stiffness or tightness. So I'd visualize it all along that same spectrum of a sensation. So it's really looking at a few other variables along it to determine whether or not, or how the best way to approach it is. So I guess kicking it off initially when someone has pain, or what do you think when you might be a little bit different because you've got a background in fighting, so used to experiencing a bit of pain. But I think for a lot of people, when they get pain, they associate it with the with actual tissue damage. So they'll have a sensation, and they'll think that's a warning sign that you're going to damage the tissue. Just like if you put your hand on a hot plate, you get the pain, so you pull it away. So that's a very kind of common kind of perception that pain is just very black and white, that it's there to protect you. If you feel anything, pull back off it. And I think as we chat through, you'll see that it's quite a bit more complex rather than that, and that'll kind of help guide around what's okay to exercise into, what you should be pulling back from.
So let's work through a little bit of an example here, because this is something that it also bothers. I could tell a lot of clients have this issue, right? So let's say that I'm actually gonna use a personal example. Quite recently, I was doing lateral raises with the cables. I was getting heavier and heavier. I was increasing my reps. At some point, I started feeling a bit of a pain in my elbow while I was lifting it up. My initial reaction was, okay, let me lower the weight. Let me see if I still feel the pain at a lower weight. Is it the rep amount? I took a couple of days off once I felt that it still was there. But how can you tell, oh, this is an injury versus this is a nagging situation? This is maybe like a pre-signal to an injury, or maybe that you're pushing a little bit too far and it's not something we should completely stop from. Like, how do I make that?
Yeah, good, really, really good question. So I think part of it will come down to your past history. So have you had that elbow tendon pain before? Is that a familiar pain that you're used to associating it with lateral raises? So if you've had that before, the behavior where it might be sore for a couple of days and then it'll ease off. You're not going to be quite as worried about getting some sensations into that. The other thing is going to be around different tissues. So when we talk about different tissues, that might be bone, joint, cartilage, muscle tissue. So there can be slightly different rules for different tissues. So tendons, notoriously very stubborn in terms of pain, and we might tend to break those down into different types. So the umbrella term is a tendinopathy, but the classic is a tendonitis, where people think it's just an inflammatory process. If you exercise into pain, you're going to create inflammation, and then it's just going to get worse and worse. And that can happen for some people. And we see it a lot more, especially in your younger cohort, where the tendon structure can be a little bit different. You might see that acute tendonitis, and we see it as we get through the age if you've had a big spike in loading. But more often than not, especially with your example with a tennis elbow, it might more be those persistent changes to a tendon, what we call a tendinosis or a tendinopathy, where you've got other factors such as nerve endings, blood vessels, that make it sensitive to loading. So here we're getting a pain signal from changes in tendon structure, but we're not creating an inflammatory effect necessarily. There might still be slight elements, but we're much, much happier to exercise into low to moderate effort levels of pain with that versus some other tissues. So for that example, it's perfect. I'd approach it very similar, where if it's quite high level, you're doing more and more reps and it's getting worse, rather than stopping the session, back off the weight a little bit, see how it feels. If that's still quite irritable, go do a different exercise. You don't have to stop the session. There's loads of stuff you can do to exercise around it. And then the big thing is assessing how it responds over that next 24, 48 hour window. Do you wake up the next morning and you feel fine? That gives you the green light to, continue to gradually load that tendon, or does it take 2, 3, 4, 5 days to settle? Which means next time you'll be a little bit more conservative on the loading. So you might only work into a little bit of sensitivity instead of, a 4 or 5 out of 10 pain.
So this is another thing. This leads me into my next question. So when we say that we're leading into like a 4 or 5 out of 10 pain, that's obviously subjective, right? From the sense that maybe a 4 out of 5 for me, for you would be, what is a 4 for me, for you could be a 2, or what's a 4 for me could be a 10. How do we get past that? How do you as a physical therapist get past that individualization between each person and their feeling of pain or their level of experience of pain.
Yeah, and it can be tricky as well. And I think just before jumping into that in terms of like pain, so there's the definition of pain from the International Association of Study of Pain is like an unpleasant sensory and emotional experience associated with potential or actual tissue damage. So it can be influenced with contextual factors such as like, when you're exercising into that pain, if you believe that it's going to damage the tendon, your subjective pain rating might be a 7, because when you get that pain experience, you're thinking this is going to rupture the tendon. So like you're suggesting, that subjective score can be very different between people just based off their past experiences with pain, what they think that pain is leading to. For you, where you've exercised into a lot of pain, you've had it before, it's very familiar, you know it's not going to damage it, you might be pretty happy to exercise into that pain. So I think that's kind of important to consider around why some people might score higher or lower. So helping them have that understanding might de-threaten it and already bump a few numbers off. But really, I kind of pick and choose around giving people what numbers to base it off, because it can be quite variable. So again, for the tendon example, I'm more interested in how long it takes to settle. It's not kicking them up at night and coming up with a kind of something that we're both happy with, where it's not going to make them really sore for multiple days, even if it's a 6 for you and it's a 3 for someone else. If both your guys' pain is settling within 24 hours and you're ready to load from that same baseline, then I'm happy, even if your 3 is someone else's 6.
All right, that makes perfect sense. And I want to look at the opposite end of the spectrum too. When you have somebody that's maybe more of a competitive athlete, or someone that was a competitive athlete, that pushing through regular discomfort has become quite common. So like if you were taking a wrestler, Division I wrestler, and you're training him, because some of the people at Lifetime Transformation you train are professional fighters, some of them were wrestlers. I'm sure they're used to, oh, this hurts, that's fine, let's put I'll just shake it off, let's keep going. When you're dealing with somebody like that has that kind of, I guess you'd say mental toughness, might not be the best word, but that's the best word I could think of. How do you deal with that when you're trying to figure out what their pain levels are and what their next move should be? Because if you just ask them, most likely their answer is going to be, it's all right, I'm fine.
Yeah, great question. So I think look at it kind of twofold. So if you know the athlete and you can build trust with the athlete, like that's going to be one of the biggest things. So if you've had the luxury of like knowing the person, so for you, I can probably call out your bullshit if you're telling me it's okay. So if you've established that rapport with the athlete, so you've got that trust, that you're both working towards that common goal, and if they're exercising and they're at risk, then it's not going to be good for anyone. So trying to establish that, kind of relationship, so that they have the ability to tell you if they are in more pain. Or the other thing around like that fighting, if there is almost an idea that you're going to have some pain just by the nature of the sport, what I try and look for is other more objective kind of things to monitor. So for example, if someone's coming back after an ankle sprain and they're telling you that their ankle feels fine, they've got 0 out of 10 pain, they're not having any issues, but then we can use objective measures such as is there visible swelling, is there a knee to wall measure where they've lost range of motion, or similar for back pain, they can usually touch their toes, they've had really bad sciatic pain, they're telling you it's fine, and you get them to bend forward and they can only get to their knees. So they've got that physiological limitation that it's guarding and it's protective, so they can tell you what you want to hear, but then you're matching it up with objective measures to make sure that all the picture fits. And we're quite lucky at Pure Sports Medicine. We had good facilities around like force-dex testing that I got you on, and I've still got those videos that'll come out eventually about your knee rehab.
Podcast comes out, they're coming out, I'm telling you. I'm going to bring them.
I'm just saving them for your next knee injury, and then I'm just going to put them back out.
I got to go to number 4 just to make it right.
So yeah, we try and kind of marry it up with objective measures. So you can probably remember I had you on the like forced X, either jumping or pushing into measures. So we can see if there's a strength output that might reflect, some pain or inhibition. So we use those objective measures alongside the subjective ones to kind of get that full picture.
So this is actually super interesting, and it's all along the same breath, because something I was thinking about, like when I was doing my therapy with you, we weren't spending most of our time doing ultrasound therapies. We weren't spending our time doing laser therapies. There was no cupping action. We weren't doing a lot of what physical therapy, when people think about physical therapy, their actual, in my experience of physical therapy for a long time too, wasn't it felt more like you were going in, there was these machines that were doing either ultrasounds or something of that nature, and you would kind of sit there, you do that for the preceding time, whatever the physical therapist told you to do. And maybe there were some exercises that would be difficult, that if you were like 85 years old, that those would be the level of difficulties. The physical therapy that I had done with you, and the physical therapy I'm seeing a lot more in like modern physical therapy, it actually much more resembles regular exercise. It resembles actual movements and athletic movements. And not that these other things don't have their place, I'm sure they do. But how come you think there's been that switch in physical therapy?
Yeah, so like when I first completed uni, I remember the difference between the ultrasound, like the real-time ultrasound versus a diagnostic ultrasound to diagnose injury. So the real-time ultrasound that physios used to use. So there was proposed benefits for that. So we used to think that the ultrasound waves had like healing capabilities. It helped with collagen alignment and things like that. And then a big shift in the way physio approaches changed, I think, is just as we've got more evidence. So then they started doing a lot of randomized control trials where they'd do ultrasound versus placebo ultrasound, where they wouldn't turn the machine on, and they're finding both people were getting better. So a case of, placebo effect. So I think I'd always be a bit cautious if your physio's using an ultrasound on it, or a laser therapy, and they're reporting or telling you about these proposed benefits. So there's a big difference between a proposed or a hypothetical benefit as opposed to an evidence-based benefit. So I think as evidence has come out, that's been a big shift with it as well. And I think sports physiotherapy, we know that you're trying to keep athletes at the top level as long as you can. So rather than getting them doing nothing and all these passive treatments, you're trying to just train around their injuries, because you don't want them deconditioning further, because then it takes you longer to build back up. And I think see a lot of kind of second opinions and complex cases. And one of the big or a couple of the key reasons why I think people fail physio rehab is those basic exercise. They get a band or they get a body weight squat or a calf raise, and their goals are back into running, and they do this banded plantar flexion for 3 to 4 weeks, going from yellow band, blue band, black band, and then they go into running, which is 8.5 times body weight through your calf complex. So there's this real gap in what you're asking. So you're right, physio in the early stages might look like rehab, and it might look like simple exercise, but then once the tissue healing's kind of occurred, we want to load it, and it should look like a strength program. It shouldn't look drastically different to what you're giving people.
Yeah, and I could tell a huge difference. One of the mistakes that I had in my experience with physical therapy was the first knee injury I ever had, the first meniscus surgery I had. After the surgery, my physical therapist was, for all intents and purposes, a chiropractor. Realistically, he was, in a lot of what he gave me was ultrasound therapies and things of that nature. Very good natured man. But I actually lost like a significant amount of muscle in my right leg comparative to my left leg. And that caused that knee to always be weaker. And I almost like I couldn't do a full body weight. I couldn't do a loaded squat, what you would say ass to grass, for 8 years after the surgery. It wasn't after my second knee surgery where I did physical therapy again with a much more modern approach, which they had added a lot more load as I was progressing, that I was able to get to it. And it kind of led me to think that I think a lot of people, the reason why when they get hurt, the reactions are so the complete 100% opposite is because they believe that's how rehab looks. Like rehab looks almost idle. But from what I'm hearing, you're also agreeing with it. It's the opposite. It's like we actually want to just push into it just really slowly and controlled.
Yeah, and again, just comes down to the type of injury and the type of tissue. So again, early stage post-op, if you've got a big swollen knee, that's where we are going to be a lot more conservative. We're still going to try and do some strengthening and different types of ways of trying to get that muscle contracting. That's where like electrical stimulation, if you've got a lot of swelling, could be effective in the early stages. So we want to get the muscle going without loading the joint. So in those early post-op stages, I'd definitely keep it to kind of minimal pain, use swelling again as an objective measure to make sure that knee's tolerating it. So if you're telling me you're ready to load, but your knee's still swollen post-op, I'm not going to try and jump into loading. But once you get into that medium or later stage, we definitely want to start to load you more gradual and more heavy. And that's where if you do have little bits of tissue sensitivity with it, and there's no swelling and it settles really quickly, that's where I'm happy to start to load you into, I know you feel something, it's a little bit sensitive, let's see how it is the next day. And then just really kind of grading back up, because like you mentioned, you've come off from an operation as well. So in your brain, you're already thinking about that knee injury. So when you go and do that first squat, even if I've cleared you to do it and your knee's looking good, you're going to be very hyper vigilant around any sensations that you're getting, which is natural because you've just had a really, really painful injury. So kind of graded exposures, as much for getting the muscle, joint, tendon used to the loading as it is for your confidence and your mental kind of aspect of telling your body that it is okay to load again, and then kind of experiencing that as well.
So I'm gonna lock up with two last questions here, and I think both of these will be really useful for the audience. So I'm actually probably gonna cut most of these two parts of the podcast and I'm gonna put them as their individual stories, because I think that so many people are gonna get a lot from it. Number one is the role of placebo or the mind on your ability to recover and your ability for general training. So like how much of an effect does believing you're going to be injured or believing that you have a massive injury already, or generally being extremely hypervigilant and worried about pain and over analytic about pain, how much does that play into what you're actually feeling and your ability to recover?
Yeah, so good, nice, simple question to finish off on there. So there's lots and lots of research out there on kind of like, pain perception, and can maybe signpost it or delve into it a lot deeper and on a few other podcasts. But I think going back to kind of what prompted me to do the further research, as an example for back pain, like you might get the people that have an episode of back pain, they've had little niggles before, they're not worried about it, they get moving, and then they shake it fairly quick. And this isn't like a structural injury, so we're not talking a disc protrusion, we're just talking a bit of a run-of-the-mill, like a strain or a sprain through the back. And then compare that to someone that might have had the exact same kind of type of injury but in their head they're thinking that they've going to be paralyzed. They've got a family history of back pain that's resulted in operation. You can see that kind of pain threat level is going to jump a lot further up. So then their coping strategies might be, instead of getting moving, getting going, they become a little bit more recluse, and then they don't load it. So we see similar examples, but a lot of research around those, what we call kind of psychosocial factors or pain catastrophizing beliefs and things like that, have a big impact on outcome. So in back pain, where there's a lot of research, it's not necessarily the severity of the injury and things like that. It can be these psychosocial factors that predict the outcome and the likelihood of persistency or chronicity as opposed to the initial kind of insult at the injury. So I think massive is a part of it.
Yeah, I've definitely seen this because I've seen this so much with people, with clients. Some clients who generally they have a more it's going to be okay attitude about their injuries that they have. They seem to overcome and be able to train, recover a lot more quickly. Well, I feel like with the clients that more they overanalyze, they think about the pain, they'll it will become a massive, in the hierarchical structure, it'll be something that is hanging on the top of their head. It feels that the injuries don't go away as fast, or it sometimes almost sounds silly to say, but it feels like it actually makes them worse. Like, it makes the recovery process so much harder, because I think from an actual practical situation that happens is when they're trying to execute whatever they're doing, their lack of confidence, they're already predispositioned that this is an injury, and this person is telling me, I'm ready to do this, but I know I'm not because I feel this thing, and that feeling is so much more true than anything he could be telling you right now. There's just almost hold back. Have you realized something like that in your practice?
100%. And again, lots of research around there. So, the beliefs is super hard. So, as trusting as you are, like, people's experience, it's really hard to tell someone something that contradicts that actual lived experience. So, like you're suggesting, if you're telling them it's going to be okay to do that lateral raise on a cable machine, and in their head they've already experienced the pain in the past, it's going to be painful. So again, that threat level is already going to be higher, and there's been really interesting studies on using functional MRIs where they map different areas of people's brain and the pain centers within the brain, and they get them even just visualizing the activities, and it can line up those pain centers. So before that person even lifts up, like you're suggesting, that system's already primed that it's going to be painful. So it comes down to how do we that's kind of our experience. So then how do we address that to get them over that barrier? And I think part of it is the education, the pain science education. If they understand more, then it de-threatens it a little bit. Then the other side is that experience, so allowing them to experience it and showing them that it's not necessarily going to result in the worst case outcome, but you just need to, on those patients or clients, you just need to tread a little bit carefully so that you're edging into it, assessing how it goes over those 24 hours. Because if you overload them and you just think it's all in your head, we're just going to load them, that pain experience is going to be very real. It'll blow them up, and then it'll become a bit of a self-fulfilling prophecy of, he told me it's going to be okay, now I can't move the next day, even though we might have damaged the tissue. So I'd tread carefully, educate, graded exposure, and then it should de-threaten them.
Well, that's awesome. And we don't got a whole bunch of time here, and I don't want to keep you. I know you're off traveling the world right now. But right before we head off, if you were to give people some general advice, and I'm not talking really here about pro athletes, I'm just talking about the guy or the gal that wants to go to the gym, get a little bit of exercise in, but they're a little bit worried about some old injuries they had, nagging injuries, soreness, stuff of that nature. They're unexperienced. What would you say would be your advice to them, and what's the best way to prevent these things from happening? Like, what would be your advice for them people?
Yeah, so I think start slow. So like if you don't have it something specific in the calendar that you've got to train for, or if you're signing up for something, if you wake up motivated to do a marathon, make sure it's far enough out because once you get sore, it's a bit of a frustrating journey. So just give yourself adequate preparation to kind of get there. Start slow. Your body doesn't necessarily love surprises, so especially tendons. So don't don't throw lots of different stimulus at it if you're not used to it. So the classic example is we see like a lot of cyclists that are cardiovascularly fit and then they try and run a lot and they've got that fitness, but then they're not used to the ground impact. So then they'll come undone that way. So I think start slow, enjoy the process of just being active. It's definitely a lifestyle. So yeah, try and just find something you enjoy doing, build up, gradually increase, and then once you build up over a few months, you'll establish that chronic workload where it's going to then be protective. So that getting there can be quite frustrating if you've had multiple injuries because you're using up some of the tolerance, and then it might get a bit sore, and then using some of it up. But once you're up there after a few months, that'll be where you're at your most kind of robust. So that's the way I'd approach it. And if in doubt, contact me if you want kind of some specific structured kind of advice on it if you're not feeling confident or you've tried multiple times. So those are the ones I'll often see if they've seen multiple physios that they've tried multiple times and they just can't quite get it. Then we can chat together around some strategies, try and identify the barriers where they mightn't have succeeded in the past, put in a really good plan to kind of get them back up there.
Well, one, that's for sure. Josh, I want to thank you so much. You're going to let us know exactly where we can get a hold of you, where we could follow you. And guys, please keep all the questions only about physiotherapy. He does not have an OnlyFans, but I'll make one for him afterwards.
See how long I'm traveling for. So
yeah. We might need to start.
So,
let me know where we can find you.
Yeah. So very new to the kind of Instagram game. I think we've only been talking about me starting it up for the last 6 months. Yeah. So it's slow to the uptake. I'm at The Real Physio, THOR, Real Physio. Not much content there, but now that I'm actually traveling, got a lot of free time, I'll try and get some stuff up there. So yeah, swing us a follow. And if you have any questions or feedback, or you want to see anything else on a podcast from me and Tony, let us know. Happy to chat.
All right, guys. You can also if you want to get in touch with Josh, you can always go to www.lifetimetransformations.com. Send us a message. We'll get it straight over to Josh and make sure he answers it. All of the Lifetime Transformation clients have access to Josh. And if you do have an injury, I highly recommend him. I put my stamp of approval on him. He's a fantastic person, and he's a great physiotherapist. Truly, if you have any injuries, he's the guy I'd go to. I send my friends and family directly to him, and I really think you guys should send yours. Josh, thanks for coming on the podcast. Now go have fun traveling the world while the rest of us slumps go back to work.
No worries. Someone's got to do it, yeah.
Someone got to do it. Ciao, ciao.
All right, see you, mate.